Want to know that this webinar will be recorded and it could potentially be used for future use, potentially on the Rush website or for other educational initiatives. And while speakers will take questions from the audience, we ask that you do not share specific details about your case or ask questions that seek a diagnosis or treatment. Rather, your question should be about the indications, risk, and benefits for Inspire therapy. With that being said, it is very easy to ask questions. There is a Q&A icon at the bottom of the screen. If a question comes to mind, feel free to click that Q&A box or Q&A icon. A box will pop up. You can type your question in, and we'll probably address those at the end of the presentation. So with that being said, we're excited to introduce our speakers tonight. We have two speakers from Rush University Medical Center. The first one is Dr. Lindsay McCullough, who's board certified in sleep medicine. She's fellowship trained, did her fellowship here at Rush, and her clinical expertise is hypersomnia, lifestyle medicine, sleep apnea, and sleep disorders. And we also have Dr. Michael Hutz, who is dual boarded in both sleep medicine and otolaryngology. He did his residency here at Loyola and his fellowship at University of Penn. He went on to become the first fellow in sleep medicine and surgery at the University of Pennsylvania, and this additional training provided him with a much deeper understanding of both the anatomy and physiology that contribute to obstructive sleep apnea. So without further ado, I'd like to pass it over to our speakers.
Thanks, Dave.
Thanks for the nice introduction, Dave. Appreciate it. We appreciate everyone's time taken out of a beautiful, although getting cool, spring evening here. So, what we want to do tonight is really give people an overview about kind of more details about sleep apnea and Inspire in general, and then kind of go over the whole procedure and why you should potentially consider it as an option for your sleep apnea. So I'll let Dr. McCullough lead us off here.
Thanks, Mike. And I think it's also helpful for you to know just a little bit about us before we dive into talking about sleep apnea and different treatments. I am a huge sleep enthusiast. As Dave mentioned, I trained here at Rush for my sleep fellowship. Before that, I grew up in Florida. I was a Florida native, did my training in medical school and internal medicine residency at the University of Florida. Go Gators. And in my spare time, I'm a big sports enthusiast, especially baseball. So Tampa Bay Rays, whenever they come to town, I'm there. Love to travel and also love to bake when I'm not working with my patients.
Oops. And then just a little bit of background. So again, what Dave had mentioned was that, so I'm a rambler through and through to start. So I actually did my undergrad med school and residency at Loyola before going on to the University of Pennsylvania, where I did a kind of an extra year of specialty training in sleep apnea surgery. And then here's a picture of my wonderful wife, Katie, and my two kids, Evelyn and Conrad, that are 4 and 2 now, and keep me busy when I'm not at work.
Okay, well, you just want to stop.
So to get started, I think it's helpful to talk about what exactly is obstructive sleep apnea. So obstructive sleep apnea is a very common condition. Nearly 30 million adults in the United States have obstructive sleep apnea, or OSA. And if we look at the words, it can help us define what this means. So obstructive or blockage during sleep, and apnea is related to breathing. So what happens is often the tongue and the throat and the airway narrow down and cause a blockage, and that can make it hard to breathe. And this may cause part of your brain to wake up. You may physically wake up or not even feel that you're waking up, and it can cause your oxygen to dip down at night to dangerous levels. And a big thing about obstructive sleep apnea, with how common it is, about 80% of people who have it don't know that they have it and are undiagnosed. Some signs or symptoms that you may have obstructive sleep apnea include snoring, sleepiness during the day, or just feeling fatigued and drained. You may feel the need to take a nap in the afternoon despite getting adequate sleep at night. You also may have trouble staying asleep at night. You might have frequent awakenings to get up to go to the bathroom. You may wake up choking and gasping, or you may not know why you're waking up, but you just may wake up frequently in the night. Oftentimes you may wake up with a dry mouth or have headaches in the morning. And some people have no symptoms or very few symptoms, and some people have more symptoms. Some consequences of untreated obstructive sleep apnea include feeling fatigued, not being able to do your job, not being there for your family, just really kind of dragging through the day. Loud snoring, this may affect you, but may affect your bed partner or your partner a lot more. Oftentimes with the loud snoring, people are sleeping in separate bedrooms. There's a safety risk for you and a public health safety risk. Because of the sleepiness, there's 3 times a higher risk of accidents in people with obstructive sleep apnea. And if you have obstructive sleep apnea, especially if it is more moderate or severe, that can really put stress on your heart and put stress on the brain and lead to, it's associated with complications like stroke, heart failure, heart attacks, and abnormal heart rhythms like atrial fibrillation. So because of these outcomes, we want to treat obstructive sleep apnea. And the treatment is aimed at opening up the airway to relieve that blockage that we saw on that first slide, where the tongue and the airway are narrowing. So what we want to start with first are some lifestyle interventions that can help reduce the sleep apnea. Oftentimes, sleep apnea is worse if you are sleeping flat on your back. So if you sleep with your head elevated or just to the side, the sleep apnea may improve, and for some people can even resolve. There are tools that can help you sleep on your side. This is a photo of something called the slumber bump, or I like to call it a reverse fanny pack that people wear at night. They have devices that you wear that can vibrate. There's tennis ball t-shirts. Lots of options to try. Alcohol also suppresses your drive to breathe and can increase the relaxation of your tongue and breathing muscles. And so alcohol close to bedtime can worsen sleep apnea, worsen the oxygen problems at night, and can fragment your sleep. So it's recommended that you avoid alcohol. And there are multiple risk factors to sleep apnea. And we'll talk about this more when we're talking about treatment and tailoring treatment individually for patients. But if you are overweight, we know that that can contribute to sleep apnea. So weight loss may help with lowering the severity and improving the breathing. So the treatment option that many people are familiar with and is kind of our gold standard is something called CPAP, or continuous positive airway pressure. And what the CPAP does is it sends in just air pressure. It's not oxygen, but to splint open the airway. If you think about the airway is collapsing, it splints it open. And it can be very effective when able to be used properly. There are lots of different types of masks, some that just go in the nostrils or sit under the nose or around the nose. And there are some that go over the nose and mouth. So when people with sleep apnea are able to acclimate and use the CPAP well, it's fantastic. And many times symptoms are resolved. They no longer feel sleepy anymore. Their quality of life improves, decreased stroke risk, decreased risk of other medical complications, car accidents. Some patients do have trouble acclimating So within the first 3 months, about 75% of patients are able to acclimate. And then after that, it drops to a little bit lower, somewhere around 60%. So we need other options as well to help people do better with CPAP, or to consider an alternate therapy. One of the other alternative therapies is something called an oral appliance. These are made by dentists that are specially trained in obstructive sleep apnea. Essentially, what they do is they are molded for you individually, and it's something you put in at night, and it moves the bottom of your jaw forward to help open up that airway and make it easier to breathe. You can find these online too, as like a boil and bite or something that they say is custom made, but that can really affect your jaw. And so you really want to make sure that you're seeing someone, a specialist in dental sleep medicine, to make this, if this is the route you're going.
And one of the comments, just to comment on these devices, if you are deciding to explore it, sometimes these can be costly. And so some people do temporarily, buy one online that is kind of like Dr. McCullough said, a boil and bite, to kind of try it out to see how well it works before they kind of invest, more money in something like a custom made appliance. But, for those patients that, have tried CPAP, may or may not have tried an oral appliance device, and are still having untreated sleep apnea, then that's kind of where I come in. And my practice is essentially a CPAP alternatives clinic. So it's trying to figure out, are there certain types of interventions or surgeries that I can help with to help treat sleep apnea? So, traditional surgery involves altering the current anatomy. And so for this patient, you can see their patient's opening their mouth. These are huge, massive tonsils in the back of their throat. And you can imagine that when this patient falls asleep at nighttime, their tonsils are kind of blocking a big part of their airway. And so for this patient, particularly in younger patients that have big tonsils, maybe removing the tonsils or kind of tightening up the soft palate can be a treatment option. For other patients, if their jaws are significantly underdeveloped and maybe that's contributing to their whole airway being more narrow, I do something called a maxillomandibular advancement surgery, where it's actually cutting the upper and lower jaw. We move everything forward and kind of put these titanium plates in place to kind of fixate it in that position. The Inspire device is very different than kind of traditional sleep surgery options. So instead of it kind of physically altering anatomy, we're not cutting bone, we're not cutting out things. We're essentially providing an implantable device that stimulates the muscles of the tongue, which is the biggest airway dilator or airway opening muscle that we have. And so by stimulating this muscle, it helps keep the airway open. And so how it works, this is just kind of a generic video where this woman takes a remote, she places it over the device and kind of activates it. And it's programmed to turn on about 30 minutes on average after you fall asleep. So you fall asleep on your own without any kind of stimulation, the device is not on. And what happens is that once it turns on, every time it senses your breathing, so there's a little wire placed between the ribs here, as it senses you take a breath in, it sends a stimulation to the muscle of the tongue to move the tongue forward and open up the back of the airway. So instead of the tongue and the soft palate falling backwards, it moves it forward with every breath and kind of keeps your airway patent or open while you're sleeping. It's set to automatically shut off at kind of a preordained time. So for most patients, it's just automatically set for 8 hours. But it can be really tailored to depending on, if you sleep longer than that or shorter than that. Otherwise, whenever you wake up, you can turn the device off. So, a lot of people say, okay, what is this new device? It's actually not that new. So it was first FDA approved in 2014 to treat obstructive sleep apnea. So it's almost celebrating its 10-year anniversary in terms of being on the market. There have been over 40,000 of these devices placed worldwide, the vast majority of which are in the US. And a lot of people, I've gotten this question in clinic that, 40,000 over 10 years doesn't seem like that big of a number. Well, initially, I think one of the biggest issues was that this was not covered by most insurances. And so for the first 4 or 5 years that Inspire was around, it was really difficult to get anyone to pay for it. So there weren't that many devices. So around 2018 is when most major carriers began covering this. And that's when probably the majority of these implants have happened within the last 4 to 5 years now. And again, kind of what it does. So this is the actual Inspire device. So this is the pacemaker. It comes from pacemaker technology, and it's about, twice the width of a quarter. And it gets placed just above the pec muscle or the chest muscle on the right side. So the surgery itself, I mean, the commercials, are kind of silly and attention grabbing, but they don't really, people will come in and say, I want the button, and not realizing that it is a surgical procedure. So it is a surgery that takes about an hour and a half long. There's 2 incisions. There's a small 3 centimeter incision that I make just under the chin on the right side. And that's where I find the nerve that controls the tongue. And I put this little sensor or stimulation cuff on it. There's a little wire that is tunneled under the skin. And then there's a 4 centimeter incision placed just above the right breast, where the actual pacemaker device sits. And then between the 2nd and 3rd rib is usually where I place a little wire that is able to sense your breathing every time you breathe in and out. Typically, it's an outpatient surgery. Most patients within a day or 2 are just basically requiring Tylenol. It's more of a soreness for most than a physical pain. Although Jan, one of my favorite patients, is gonna tell you that she had a little bit of a slightly rougher post-operative course than most, and that's why I actually enjoy having her share her story, because it's not always helpful when someone had a perfect recovery and perfect surgery and perfect outcome, and it's not necessarily a realistic view. So, but in general, within a couple of days, most people are on kind of back to kind of basic activities. I do request that people don't do any heavy lifting or kind of significant workouts for about a month after the surgery to allow everything to heal. But then after that, you're basically have no further restrictions. The battery itself is about 11 years. So right now we're seeing, since the initial patients were implanted almost 15 years ago now, with this thing called the STAR trial, which was published in 2014 and kind of helped with the FDA approval. And they're showing about every 9 or 10 years is when the battery is going to have to be swapped out. And how that works is that we would just reopen the incision over the chest. We take the battery out, we unhook the wires, put a new battery in, and replace that. Again, it's an outpatient procedure. The biggest thing that is new within the last year is that Inspire is now MRI compatible for basically MRIs of the entire body. So before, the big thing was you couldn't get any MRIs of the chest, abdomen, or pelvis, and that was a big problem with patients that had a history of breast cancer or prostate cancer or had spinal issues. And now the nice thing is that MRIs are compatible to an extent. So the 3 Tesla, it's called 3T MRIs, are not compatible with this device, but 1.5, which is a slightly kind of less powerful MRI, is compatible with any part of the body. So that's been a big help for a lot of patients. Again, how it works is that about a month after surgery, every patient will get a remote, and it's customized to the settings that are kind of appropriate for you to start with. The remote is used to kind of turn the device on and off. You can pause the device in the middle of the night if you have to wake up to use the restroom, or you're thirsty, you want to grab a drink. And in the morning, the white button is the off button, and that's how you shut it off if you're getting up and going about your day. So one of the big benefits of Inspire compared to a lot of the other sleep surgeries that we've had is that this is totally customizable. So 1 month after the implant for the procedure is when you'll follow up with Dr. McCullough in her office, and that's when the device actually gets turned on. And so this is kind of one of the old school iPads they have, but we basically have new iPads that are synced to the device. And we find the appropriate settings to kind of just barely move the tongue forward. And we start people at a very low setting where it's almost, they can't even feel the device on, which is the purpose. We don't want the device waking them up. We want it to be very comfortable. And then how it works is that each week you go up 1 level on the device. So you go up 0.1 volts each week, and you slowly kind of increase and allow your body to acclimate until you find a setting that you feel has improved snoring, has improved symptoms of your sleep apnea, fatigue, whatever symptoms that we're focusing on treating. If you kind of address those, that's when we stop going up on the device, and we end up getting a new sleep study about 3 to 6 months after, while you're using the device and making sure that it's doing what we think it's doing. In terms of kind of results with this, so there's been over 200 studies that have been published in basically across the board in our major ENT journals. The big study was in the New England Journal of Medicine, which is arguably the most important kind of impact journal that we have in medicine, showing the efficacy of it. The initial STAR trial, was published in 2014, which is this initial study in the New England Journal. And since then, they've done 5-year follow-up, and now they're getting close to publishing their 10-year follow-up data, which has fortunately shown pretty good, consistent outcomes with patients basically doing just as well 5 years later as they were initially, which has been great. There's something called the ADHERE registry, which is this international registry of Inspire patients that we're a part of at Rush. And basically we're following, 5,000 patients, and we're almost at that goal across the board, internationally, in terms of following these patients, studying our Inspire patients, making sure that we're optimizing outcomes in every way. And basically the studies show that Inspire can lead to significant reductions in sleep apnea, snoring, improved daytime energy levels, less sleepiness. And, just kind of clicking through the next slide. So studies have shown it can reduce sleep apnea severity by 78%, or the AHI, which is kind of the number that most sleep studies are graded by. 82% reduction in bed partner reported snoring. So when spouses or significant others of the patients have graded kind of their snoring pre and post operatively, it's been reduced by 82%. And then 93% of patients are really satisfied with their Inspire therapy. And what's nice is that, one of the problems that people have had with CPAP is that their adherence or their ability to use it on a regular basis is diminished. So if you're only using your CPAP 2 or 3 hours a night, the rest of the night you're going untreated. And so ideally, whatever treatment you're going to do, it's going to treat your sleep apnea through the whole night. So the average is almost 6 hours a night that patients are using their Inspire. So the big question that a lot of people have is, is Inspire something that is right for you? So you have to be diagnosed with at least moderate to severe sleep apnea. So if you've had a sleep study and it only shows mild sleep apnea, then you're not a candidate. If your sleep study shows really, really severe sleep apnea with an AHI greater than 65, then you're also not a candidate. So you have to kind of be between this number of 15 to 65 events per hour. You have had to at least tried CPAP. So a lot of patients that get diagnosed with sleep apnea come to my clinic and they say, I want to go straight to Inspire. And I say, okay, that's fine, but then you're going to pay out of pocket for this, and it's going to cost you probably 50 grand. Almost every insurance provider now covers this, but you have to have at least tried CPAP. So if you come to my clinic interested in it, I'll have you see, Dr. McCullough or, your own sleep medicine provider, just to establish CPAP, to at least try it. And for 2 reasons. 1, if CPAP works great for you, then we've avoided a surgery. And 2, we can at least play the game, unfortunately, that insurance will not cover it if you have not at least tried CPAP. Right now, there's pretty strict BMI criteria on this. So if you have private insurance, your BMI, or body mass index, which is this calculation of your height and weight, has to be below 32. If you're on Medicare, that number increases to a BMI of 35. So sometimes we have to work with you a little bit to try to get your weight down low enough to qualify. And that's also kind of for 2 reasons. 1, it's an insurance issue. And 2, the initial studies basically showed that patients that had BMIs less than that had better outcomes than patients that had higher BMIs. And then, for most people, you have to have an age greater than 18. Actually, what's been great is that Inspire was just FDA approved for patients with Down syndrome, now as young as 13 years old. So a lot of Down syndrome patients have a very difficult time tolerating CPAP. And so now it's an option that has been working pretty well for patients with Down syndrome as well. The last thing is that, when you come into my clinic, I do a full kind of head and neck exam. I typically take a look with a little camera and see if there's any kind of obvious anatomic or other structural problems. But the big thing is that there's something called a drug-induced sleep endoscopy. And that is about a 20 to 30 minute procedure in the operating room where I give a patient propofol through their IV and I put them to sleep. So you're slowly kind of drifting off to sleep. We're recreating your snoring and your sleep apnea. And then I'm taking a look with a little camera through the nose at the back of the throat to see exactly kind of what part of your throat is collapsing. About a third of patients that undergo that exam, their throat is closing in a type of way that Inspire is not a good option for them, unfortunately. So we have to talk about some of the other types. There's 6 or 7 different types of surgeries that I do. So if Inspire is not one of them, then we can kind of look at some of the other options. And then the other 2/3 of patients kind of pass that exam and we talk more about it. But that DICE or drug-induced sleep endoscopy exam is required kind of before we proceed with surgery. So now this is to kind of toot Dr. McCullough and my horn a little bit, just to help you understand why, if you decide to pursue this, why we think it's in your best interest to kind of trust us to help take care of you. So again, in US News and World Report, Rush University Medical Center has been ranked in the top 20. For the last couple of years, the ENT department at Rush that I'm a part of has been ranked in the top 25 in terms of ENT programs in the entire country. We're the most experienced center in the state of Illinois. So we were the first program to implant 100 patients. Currently, we have over 200. I think we're up to 210 patients that we're implanting, that we've implanted and are currently managing between myself and Dr. McCullough. And we have high success rates, kind of above 80%, which is above the national average. And because of how many of these types of surgeries we do and the experience that we have in managing Inspire patients, we also end up taking on kind of the most challenging cases, including revision surgeries. If you've had Inspire done at another institution and something's gone wrong or hasn't gone well, then we help with that as well. Other reasons, so research in the field of sleep apnea and sleep apnea surgery is a really big part of what we do. So we're one of only a few centers in the entire country that does something called drug-induced sleep endoscopy with positive airway pressure. So this is part of that DICE exam I was telling you about. So we actually use a nasal CPAP mask and we take a look with the camera through the nose at the back of the throat. And then while we're sleeping, we actually increase the pressure on the CPAP machine while we're watching your airway and see how much pressure is needed to open up the airway. And we're doing a lot of research with Rush and a couple other institutions looking at how we can kind of optimize our surgery outcomes, particularly with Inspire, kind of looking at these different diagnostic tools that aren't currently utilized. Again, I saw one of the questions was, does Medicare cover this? I have not come across an insurance company, and Dave McMurray from Inspire can help me with this, but of all the patients that I've seen, I've not seen anyone that the insurance no longer or does not cover Inspire. So Medicare, Medicaid, Blue Cross, United Health, all of these different types of insurance providers now cover it, which has been very helpful for getting patients access to care. So I have talked far long enough. So it is my pleasure to introduce Ms. Jan Lancic, who is gracious enough to be our patient ambassador. And Ms. Lancic was a patient of mine and also a dear friend of mine who, she can tell you her story, but basically received the Inspire implant about 1.5 years ago now. And she's going to tell you a little bit about her story. So we're really appreciative of your time, Jan, and I'll give you the floor here. And I think you need to unmute yourself again.
Okay, can you hear me?
Beautiful.
Okay. Well, I've known Michael for many years, Dr. Hutz. I knew him when he was a medical student, and that's showing my age, but anyway, I was brought to Rush at the time because the hospital I was going to, the doctor, they no longer had a sleep specialist. So I was offered the opportunity to either go to the University of Chicago or to Rush. And of course, I went to Rush and had a couple of sleep studies with the sleep specialist. And the last one, she recommended a pressurized CPAP, and I couldn't wear it. It was always on the floor when I woke up. So then she says, well, maybe you would benefit from this. So I had an appointment and I could have fallen off the chair. He pulls his mask down and he goes, remember me? And I was floored. And I go, I don't care. Everything's gonna be fine now because Michael's gonna do it. And I was just in awe. The procedure went well. But I had a little complication afterward. I couldn't talk for 2 days. My tongue was excruciating. I couldn't talk. And he said, well, it should go away, and it did. It was like 2 days and it was gone. And I never took aspirin, never took any kind of pain reliever because I didn't need it. In those 2 days, I couldn't even swallow water, so I didn't take anything. But it was the best thing I ever did. I tell everybody, ask me, how was it? I go, oh. And one of the nurses today asked me, she says, how's your Inspire? And I go, great. She says, she wants it, but she's not. I said, well, I didn't have to pay for anything because Medicare and Blue Cross pay for it. Well, as she's still working, she doesn't have Medicare, so she's going to have to wait, she said. And she wanted to know how much it cost. And I said, I honestly don't know because I never got a bill, But yeah, it's been, in fact, I was telling him that at one point I was going to get one of these portable CPAPs. One of the doctors I was on a vacation with had this, and I go, God, and she told me it was like $600. And I go, don't want to spend $600 on this little thing, And that's when this turned up with the Inspire, and I'm just thrilled to death. And I am singing its praises to everybody. They find out I had the Inspire, and that's it. Just tell them it's just wonderful. And now the hospital I go to is starting to do the Inspire. And
Yeah.
it's just, what can I
Yeah.
tell you? What else do you want to know, Mike?
Yeah. Well, thanks so much, Jan. That was awesome. I appreciate you joining. And I think,
Oh,
again, what I was sharing before is that I think it's helpful. I mean, you actually had kind of an unusual, discomfort in the tongue. And part of that is, during the surgery, we have to put these little needle kind of electrode sensors in the tongue. And you were in a lot of pain, which is actually more than usual. But, within a couple of days, you had kind of bounced back and you've done really well. And I think, what you've shared too is one of the benefits of it for you has been your international travel. And I know you do all this crazy travel all over the world.
come on.
And it's been probably a lot easier with your little remote to
It will be. It
travels
will
than-
be, yes. I just want to thank you very much for it. And I keep singing your praises. So.
It's been a pleasure. So
Thank you.
Jan, stick around because thanks everyone for your time. Right now, we're going to start going through and answering any questions that we kind of come up in the Q&A. And Jan is here as well. So if you guys have, questions specific to Jan in terms of, how her, how she feels when it's on and different things like that, feel free to write that down. In terms of our information, so, I have offices in Oak Park, and our main campus downtown at Ashland and Harrison. And then Dr. McCullough has her main office at the main campus downtown. And so, whether or not it's to, see us to establish care, to see Dr. McCullough to help, maybe sometimes it's just helping you get better use of your CPAP machine and we can save you a surgery. Or sometimes people come in my clinic and they have really hard time breathing through their nose. And if I do a nasal surgery or kind of optimize their breathing in the nose, then they use their CPAP better. So, if you have sleep apnea and it's not being treated, there's a lot of different ways that we can treat it. So, don't hesitate to come see someone about it, because again, as Dr. McCullough said, it's a little bit like high blood pressure. Sleep apnea itself won't kill you, but it causes a lot of, puts you at risk for a lot of other things that can be really damaging for quality of life and long-term things. So we're here if you need us. But I think we're going to start going through questions one at a time. And please feel free to kind of write more questions as we go here. So Dr. McCullough, I don't know if you want to start reading through questions and we can kind of take turns answering them.
Sure. And this question, I'm not sure I know the answer to, but it was about an induction stove which uses electromagnetic field. Can I use an induction stove with Inspire? I think that's okay, but I would defer to the Inspire crew about that.
Yeah, I can't say I have been asked that question before. So Dave, I don't know if I'm sure you're still on the call if you have any
Yeah,
concept of that, but that's something we could definitely, email the engineers at Inspire and find out the
Mhm.
specific answer to that.
yeah, there shouldn't be any issues with an induction stove. I mean, we have technical guidance on other electromagnetic machinery, but there's no issues or no data with an induction stove, so we should be fine.
And the next question, Dr. Hutz, this is probably best for you. Can you explain, oh, I lost it, how to get the wire from the throat?
Yeah.
Device.
So basically how it works is that, through the little 3 centimeter incision that I make under the chin, and I usually, that heals actually very, very well. And I try to kind of mark you in the pre-op area to hide it in kind of a natural, either shadow of the jawline or kind of a natural skin tension line. But basically through that incision, there's this kind of long, very thin tube that actually tunnels from the incision here to the incision from the chest. And so it kind of just bluntly goes through and comes out the incision in the chest, and we can pull the wire under the skin through. So it's not actually kind of opened up between that whole area. It's just kind of tunneled under the skin and taken out from the chest area.
The next question is, can you have an Inspire implant if you have a pacemaker? And yes, you can. We have several patients who also have a pacemaker.
Yeah, and with pacemakers, the big thing, so pacemakers or loop recorders that are implanted for cardiac patients, we basically just have to we have to place the actual battery, the pacemaker device for the Inspire, 6 inches away from the pacemaker or the loop recorder that you have. So just as Dr. McCullough said, we've implanted a number of patients that have had pacemakers. And as long as you just kind of keep it away from that device, there hasn't been any kind of interference between the two.
What is the long-term or yearly maintenance of this device? So typically, I can take this first, and Dr. Hutz, whatever you want to add onto this. When you first get the device, Dr. Hutz mentioned the activation, which occurs about a month after. And in the beginning, you're titrating or you're increasing your voltage and figuring out which setting is right for you. So there's a few more visits in the beginning and adjustments. And then we want that sleep study 3 or 6 months out. After that, if you're doing well, usually we'll do a sleep study every 6 months to a year after that. And just to check in like you would with any of the other treatments for sleep apnea. And the battery replacement would be the only other maintenance of this device that I'm aware of.
Yep, no, exactly. So the battery will be changed every 9 or 10 years. And there's actually a little like kind of sign that pops up on the remote and also online with the Bluetooth that tells us when that battery is starting to get a little bit lower. But once we get to the kind of the right setting for you and the initial sleep study looks good, then it ends up being, maybe every other year we'll do a sleep study, or every couple of years if things are really stable, just to make sure, unless there's some kind of change in symptoms. So this question is, do I do the procedure at Copley and Aurora? I do not, unfortunately. I do these surgeries at Oak Brook, at our Rush Oak Brook Surgery Center, the Rush Oak Park Hospital, and the downtown campus. But so I can see you, in clinic at the Oak Brook Center, which is probably about 25 minutes or so from Aurora down 88. But I do not do the surgeries at Aurora, unfortunately. And then Dr. McCullough, I can answer this one. So of those, 210 patients, the question is, what post-op complications have there been? So the most common complications that we have with the surgery, so the 4 major things that I tell people, there's a little nerve that controls the lower lip that runs kind of just near this incision. So when we make that incision, oftentimes it can get kind of stretched or irritated. Sometimes people can have a little bit of weakness in that lower lip for maybe 2 or 3 weeks afterwards, and then that nerve heals. I have not seen that be permanent. Some of the other complications. So patients can have what's called a hematoma. So a hematoma is basically where underneath the incision that's closed, you continue to have bleeding and you get kind of a big blood collection under the skin. Of those 210, we've had 4 hematomas now. Three of them I'm certain were on kind of high dose blood thinners. So there were patients that were on Eliquis or Plavix or Coumadin, and it puts you at a much higher risk because they had to restart kind of those blood thinners kind of sooner than we would like them to be post-operatively. But it's about a 1% risk of having a hematoma after surgery if you're not using any blood thinners. Infection rate is another one. So, it's just like a knee replacement or a hip replacement. It's a foreign body. So if it gets infected, it's a really big deal because antibiotics alone typically will not treat that. So you actually have to remove the entire device. We've had two infections out of 210 patients. One of them happened because a guy started shaving over his incision about a week after surgery. And we advised people not to for the first 4 weeks. And he basically nicked the incision because it was a little numb around it and it got it infected. And basically the entire thing had to come out. The other patient, we're still not entirely sure why their device ended up getting infected, but it's done under very sterile conditions. And so it's very rare to have any infections post-op. Another risk is called a pneumothorax. So a pneumothorax is a tiny little hole in the lung. And that happens when I put this little wire between the ribs. It's about a 0.5% chance total. Of 210 patients, we've had 0. So we've never had that happen at Rush. I've never personally seen that happen, but it has been reported in the literature. So those are really the main complications. And in general, it's been pretty safe device.
All right, can you see or feel the device above the right breast? So you may see a little bit of an indentation. It's not super visible. And if you touch it, you could feel it as well. But it's hard to explain. Maybe even Jan, you could say how it feels and what
Jan, you don't need to pull your shirt down for us.
I'm
but
not gonna.
Yes.
You can feel it. And I was teasing Michael. I said, why couldn't you make it a little lower? Now I can't go strapless, It's great. It doesn't know, and at my age, who cares? As long as I don't use a CPAP, I'm just loving it. And,
I will say, so that varies greatly with people's body habitus or their body type. So people that, are either bigger breasted or a little bit larger, they have thicker skin or more adipose tissue. So that device is going to sit deeper on them. And so you may be less likely to feel the outline, but if you push deep enough, you're going to feel the device there. But the vast majority of patients, it does not bother them that they can feel it. I will say that there's a newer technique that I do for patients that request it, where it was nicknamed the tank top incision. So you can actually make an incision almost in like the bra line for women to kind of hide that incision so that you don't have it over the chest. All right. So one of the questions was, I have severe sleep apnea. What is the number to determine if qualified? So that number has to be between an AHI of 15 and 65 currently. And there's different ways to grade a sleep study with different criteria. And so that would be something that we could help you understand based on how many kind of events per hour that happened.
Yeah. And the AHI can vary based on how much time during a sleep study you sleep on your back versus your side. If you have had significant weight changes, that can vary the AHI. Or sometimes there may be a different type of surgery that you may benefit from having before the Inspire that could qualify you to fall into that AHI criteria. So if you don't have that AHI, there's still worthwhile to talk to your sleep doctor about what are some things that you can do.
So from the question is, where do I start and what is the process from beginning to finish? So kind of the start is, if you've already been diagnosed with sleep apnea, you've already tried CPAP, then the next step would essentially be, scheduling a new patient appointment to see me. And At that appointment, I kind of do a thorough sleep history and medical history and all these different things. I do a thorough head and neck exam. And then from there, if you're a good candidate, the next step would be scheduling you for that sleep endoscopy procedure. So the sleep endoscopy, again, is that 20-minute outpatient procedure that is kind of a same day. So you come to the operating room, we put you to sleep. 20, 30 minutes later, we wake you up and you go home. And that's really kind of the airway exam that you have to pass in order to qualify for the Inspire. If you qualify, then, we do a follow-up. We kind of go over again all the details, risks and benefits, kind of all the process of the surgery itself. And then we schedule your surgery day. Surgery day is about, you show up 1.5 to 2 hours before your surgery. The surgery itself takes about an hour and a half long. We keep you for about an hour and a half or 2 hours in the recovery room, and then you go home the same day. 1 week after surgery, we have you do a quick wound check with one of my physician's assistants. And then 1 month after surgery is when you see Dr. McCullough to actually turn your device on. So the first month after surgery, if you have a CPAP, we want you to keep using that every night. But otherwise, you're not going to feel anything. You're not going to, have the device on for those first 4 weeks. Once we allow the body to heal, we turn the device on. And you start using it every night, and you go up kind of 1 level each week. About 4 weeks after that, we do a quick video visit check-in. Another 4 weeks after that, I see you back and kind of go through everything, see how you're doing. If everything's great, then we order a new sleep study. If that looks good, then we keep you at that level that you're on. And you see Dr. McCullough every 6 months to a year, and we keep you using the device every night. If you're struggling with it, if it's not totally optimized, if your sleep study comes back and your sleep apnea is not as well treated as we'd like, there are a lot of different advanced kind of titration things that we can do with the device. We can change settings. We can do a lot of different things to kind of optimize it to make it more effective.
Can I qualify if I have mild sleep apnea, but I cannot tolerate the CPAP machine? So as of right now, if you have mild obstructive sleep apnea, you don't qualify for the Inspire, but there may be some other alternative treatments that you would qualify for. There's the oral appliance that we mentioned. There may be positional therapy. There's another treatment called the Excite OSA, which is a neurostimulator device that you use during the day. So there are other options, especially if you're symptomatic from your mild sleep apnea. I'd recommend coming in so we could discuss more.
Yeah, and the other thing to note too is that, if that mild sleep apnea was diagnosed on a home sleep study, sometimes that underestimates the severity of your sleep apnea. So if your AHI, that number was, 14 on a home sleep study, we may get an in-lab sleep study and have you stay overnight because those are a lot more sensitive. And usually that number is going to go up high enough where you probably did have moderate sleep apnea. It just wasn't getting picked up on that home sleep study. So there are things to consider. But if on an in-lab sleep study, it's still less than 15, then unfortunately insurance does not cover it right now. So the question is, what if the device fails? So, if, we go through, we implant the device, we, try every single setting that is possible, and it's still not working. There's a couple different options that we can do. One is sometimes there's different surgeries that we can do in addition to it to kind of optimize how well it works. Some patients have actually gotten an oral appliance device that they use at the same time as the Inspire, and the combination of those two can work well. If you go down this road and you're like, this is for the birds, I don't want this anymore, we can remove the entire device. I will say that of those 210 patients, it's been less than 5 that have requested it to be removed. So in general, people are pretty happy with it, but certainly we can take it out if it is really bothersome or for whatever reason is just not working well for you.
How do metal detectors react at airport security? So if you receive the Inspire and you have the remote, you'll also get a card that you'll show airport security when you're going through, so you can let TSA know, and so that they can take the necessary precautions, because you would turn off the alarms with the device.
Yep. So most people, if they go through like the airport, it does not set it off. But again, I think you keep a little pacemaker card, device card on you just in case something happens. This next question is, has anybody's body ever had an allergic reaction to the material? And what is the material and device parts and wire made of, et cetera? So the actual implant itself is titanium. The wires and things, in all honesty, I don't know the specific kind of elements that it's made out of. So we'd have to look at the website specifically. There's been one patient that we think may have had a reaction to one of the components of the wire, and it caused the wire to actually extrude from the neck. So out of those 210 patients, we were actually able to kind of safely reimplant that wire, and they didn't have any further issues. But that's the only one that we think that maybe they had some strange reaction to the wire. But we haven't come across any other kind of case reports of that happening thus far.
I'm going to have my HOV at Rush Oak Park September 8th. How can I know if I'm a candidate? I'm not sure what HOV means, if that's a sleep study or office visit. But if you talk to whoever you're seeing, or Dr. Hutz or myself or anyone at the sleep center, they should be able to answer that question for you specifically.
And again, knowing if you're a candidate is, just to summarize again, you have to be older than 18. Your AHI has to be moderate to severe, 18 to 65. On private insurance, your BMI has to be less than 32. So you can calculate, type in BMI calculator on Google and you can put your height and weight in. If you have Medicare, it's got to be less than 35. And then, and then the other thing is that you cannot have more than 25% of your night with central sleep apnea. So central sleep apnea is a totally different type of sleep apnea that, they would tell you is based on the study, but it has to be predominantly obstructive where the throat actually closes. Otherwise, Inspire does not work for you. Jan, maybe you can answer this one. So one of the questions is, what does it feel like when it's on? If you're still awake when it turns on, is it difficult to fall back to sleep, or kind of how do you deal with that when that happens?
You get used to it. You can feel like the tongue is going to move. But once it's the initial turning on, you feel it. Then after that, you don't feel it. I don't feel it.
And I will say, depending on, how high of a voltage you need, there are patients that have to be turned up to a point where if they wake up, it can be difficult for them to fall back asleep with it on. And so that's why the device actually has a pause button on it. So you can, if you wake up and you're trying to fall back asleep and can't, you can hit the pause button, and it's pre-programmed to pause for, 15, 20, 30 minutes, whatever we decide. And it allows you to kind of fall back asleep without it on, and then turns back on while you're sleeping.
And similar to that, when you do turn it on at night, there's a start delay, or the delay in terms of it turning on once you first get into bed at night.
I'm sorry, I didn't hear that.
What was that, Jan?
I didn't hear what you were saying. I couldn't.
Oh, I'm sorry. When you turn it on at night, when you initially turn it on, right, there's a delay before it actually starts working to allow you time to fall asleep initially.
Right. You have them set to
Yeah, exactly.
start when you want.
So what type of sleep studies are done? So, as long as everything looks good and we're kind of happy with your symptoms after the surgery, and we feel like you're in a good place, right now we're just ordering a new home sleep study. So we order a home sleep study. It's called a watch pat study. So it's essentially a little oxygen pulse ox on your finger. There's a wristwatch, a little sticker that you put on your chest. You sleep in your own bed, and then you actually toss the device the next day. You don't need to return it. And it electronically sends all that information to Rush. If, that first sleep study doesn't look great, or there's other reasons why, a home sleep study is not right for you, then we do bring you into the lab, and we can do what's called a titration study, where the device, while you're sleeping, the tech can actually change the settings on it to go up or down to try to pick the best setting to be most effective for you. So usually starting with a home sleep study, if it's not working great, then we go to the lab and kind of do some more advanced evaluation.
what is the time frame to have this installed, or surgical time frame the day of the implant?
Yep. So the surgery itself, you're under anesthesia for about an hour and a half to 2 hours. And the surgery itself takes about an hour and a half long. It is under general anesthesia. So you are asleep completely. There's a breathing tube in. And then at the end of the surgery, you're woken up, breathing tubes taken out, and you're brought to the recovery room. Is it okay to travel back and forth for multiple appointments if you live out of state? Yes. So, depending on where you're coming from, sometimes I do like people, if it's from a far distance, to stay one night in the Chicago area just to make sure that you're doing okay. So the first night after surgery to get a hotel room. If you're from a neighboring state, that's within a couple hour drive, like Wisconsin or Indiana, then it's okay to drive home that same day. And I've implanted plenty of patients that live out of state that have gone back the same day. So the question was, why did those 5 choose to have it removed? So of those patients, before the device was FDA approved for MRIs, the majority of patients that requested to be removed, it was because they needed an MRI for some other problem. So either there was concern about a stroke, they needed an MRI of the brain, they were having spine issues and they needed an MRI of the spine, or they, developed some kind of cancer. And so 3 of those patients had it removed because they needed to have it removed for an MRI. Now that's no longer an issue since it's compatible. 2 of those patients, they just could not tolerate the device at all and, didn't like the way it felt. And so they just requested to have it removed.
The next question.
Jan, maybe you can answer what it
Yeah.
feels like when it's on, and if you can talk, if it's stimulating the tongue.
Oh, yeah, I can talk. You can't stop me from talking.
I
I
will
don't have a
say
problem with that.
the speech for most people, if it's high enough, your speech sounds garbled. So, if the tongue starts moving forward while you're trying to talk, like this, and then it goes back to normal.
You do, you talk like you got a lisp. Yeah.
So you would know immediately if you forgot to turn it off in the morning.
I look forward to turning it off.
Yeah, right.
No.
All right. So the question is, the wire from the neck to the device, you said, is threaded through a tube. Yeah. So it's this very long, tiny, it's about probably, I don't know, a ½ centimeter wide. And the tube is basically inserted at the top, and it's kind of under the skin and pulled out through the chest incision. So it doesn't stay in. The only thing that stays in is the wire, but it basically allows you to feed the wire from the neck, and then you kind of pull the tube and the wire out through the chest incision. And that's how that device, how the wire gets connected between the two.
All right.
Any other last pressing questions? Otherwise, we really appreciate you guys taking, an hour out of your nice summer evenings, and especially you, Jan, to spend some time with us.
No problem.
So again, thanks so much for your time. Reach out to us if you want to, schedule an appointment, if you want to learn more about it. If you live out of state and you just wanted to schedule a video visit and kind of chat more about it first, you can schedule a video visit to start. But then we're happy to help in any way we can.
Okay, thank you.
Thank you
Thanks,
all for
everyone. This
coming.
will conclude our webinar. Thanks, Dr. McCullough, Dr. Hutz, and Jan. Thank you.
Thank you.
Of course.
Thank you
Night,
so
everybody.
much. Good night.